All right, good morning. It's Chelsea with Wound Care University. We're back for another exciting episode, another great chat with our recurrent guest, Dr. Marcus Gitterly. I guess you're just kind of stuck with us on these, so welcome back to the show.
Glad to be back.
This morning, we're going to talk about when is a wound actually healed? Is it ever okay to break up with your patients? And that sounds like probably a very simple question, but maybe not something that's so straightforward when actually in practice. So when can we safely discharge patients? We know that technically a wound is considered healed when it's covered by epithelialization with skin. But what are some caveats there? You know, you don't see drainage, you see like little shiny baby skin on top, but what other issues could we be looking at here?
Well, so this is a great subject and one that I think should get a lot more attention. That wound actually is not healed at the point where it is epithelialized. If you're seeing the patient weekly, which is considered a best practice, you're going to be seeing them close to the time when that wound is covered with a layer of keratinocytes. That's what we mean, when we say that a wound is epithelialized. But that wound is technically not healed. And what I mean by that is when you think about the healing cascade, which begins with hemostasis and then progresses to the inflammatory stage and then hopefully quickly to the proliferative stage, where cell division is happening rapidly. You have the wound bed becomes shallow, and then you get epithelialization. But remember, there's a fourth stage. It's very, very important. It's called remodeling, and the remodeling phase actually generally takes much longer than the other three phases in total. And so it's going to be at least 8 months before that block of tissue, that region achieves its final configuration. And so I think we need to broaden our view of what healing means and quit telling patients they are healed when they're epithelialized. So when I put it that way, it seems obvious, right?
Yeah.
There's a lot left to do. And so what does that mean? What are the implications of that? Well, first of all, early in the early days after epithelialization has occurred, generally we're dealing with a very thin layer of cells. And depending on what part of the body, we're often dealing with very high risk areas like the foot.
Yeah.
Um, that layer is just a few cells thick, nowhere near robust enough to stand up to typical activities of daily living. And so in that early phase, post epithelialization, it's a best practice, I think, to continue to see that patient at a weekly cadence,
Mm-hmm.
because you're going to identify deviations from things that the patient ought to be doing to support that thickening of the epithelium, moisture management, for instance, shear and pressure protection, right?
Yeah.
And so you want to catch it early if they're going the wrong way. And you also want to reinforce that thinking that they're, because the patient doesn't understand the healing cascade. They don't realize that they're really not healed. That tissue has a long way to go. It's collagen is not cross-linked. They really don't have the robust tissue under that epithelial layer that they need. And okay, and then let's throw in some etiologic variables here. Most of the time, we're dealing with wound etiologies that are themselves chronic conditions, like
Exactly.
diabetic foot ulceration, venous insufficiency, venous ulceration.
Yeah.
And when that's the case, we're dealing with a whole other set of variables that have to be managed in order to keep that patient from having a recurrence, either in the same place or just in a new place because of that underlying condition. So how do you do that? I think a lot of people are waking up to this notion, and expanding their view of what it means to be a wound care provider from this circumscribed care model, kind of the one and done and have a nice life, good luck.
Yeah.
Come back and see us if you have, another wound. And they're switching to, I think, a more appropriate model, which is we take ownership of the preventive mission. And because who better? What do we do? Send them back to a primary provider who isn't steeped in this stuff. They don't understand biomechanics. They don't understand pressure and shear the way we do. They don't understand why, diabetic footwear is built the way it is. They
Yeah.
don't understand what deviations from standard diabetic footwear have been validated, like, certain running shoe brands have been validated as protective enough. So for all those reasons, why would we not, embrace that mission? It's not like, we, we don't know the patient already. We do. We're established with them.
Yeah.
We also know, we know all the pitfalls associated with that patient. We know their bad habits. And
Absolutely.
So anyway,
Yeah.
that's
I
my
like
view of the notion of
I like
time.
that line of thinking and that reasoning. I mean, for like you said, it's a chronic condition. If you have venous stasis, if you stop compression for whatever reason, even if it's hose at home, that problem is going to for sure be recurrent. If you're diabetic and have DFUs, that's a chronic condition. If you stop wearing your appropriate footwear, if you're not offloading how you're supposed to, especially if you have something like a Charcot foot, you're going to end up with a DFU again. And I guess it would be kind of a comparison. If you are diabetic, even if you're well controlled currently, that doesn't mean you stop seeing endocrinology, right? If you had a kidney transplant and you're doing okay right now, you still need to see nephrology. These are chronic conditions that go on forever and ever and ever. So it makes sense that wound management for chronic conditions would kind of fall under that umbrella for sure. And I'm sure, there are outliers. Someone that, let's say, had like a C-section dehiscence. This isn't their chronic thing.
Right, exactly.
You
That's not a
can
chronic
send them on
problem.
their way and say, have a nice life,
That's right.
ring the bell,
Right. That's right.
enjoy your
That,
baby, see you never. Um, but
yeah.
even then, we do have to have those conversations with those folks, even that, especially in
Mm,
those early days after you are
yes.
healed,
Right.
it's still very vulnerable in those areas, especially like, for instance, a C-section area would have to be protected from moisture, sitting too long, chafing, whatever. And even once it's fully remodeled, it's only
hmm
80% the strength of what it
Yep.
was before you had that
Right.
wound. So it's a
Right.
constant, it's never mint condition is what I always tell my patients. Like, it's
Yes.
better than it was before, but it's never 100% after that.
And part of what we can do for a patient either way, in either case, is we frequently compress our aftercare instructions, into an abbreviation like that. Aftercare was discussed and precautions were given and patient understood or expressed understanding. And that's all well and good, but if especially in the patients with comorbid conditions, the patients with chronic conditions, chronic wound etiologies, it's going to be very important that they're, like, for instance, in the venous ulcer arena, how are they doing compression? How old are their long-term compression devices? Are they actually using them? Can they use them? Do they have any new dexterity or mobility issues that might impair that? And so we might need to help them adapt the plan, going forward.
Yeah.
But even in your C-section example, one of the things that I think we should include in aftercare, besides the moisture, and shear protection, friction protection, instructions, is nutrition. Because when you
Ooh,
think
yeah.
about how much remodeling of collagen has to occur, you consider the fact that, when that wound is just become epithelialized, the underlying tissue has not generated all of its dermal replacement structures, for instance. So we've got, collagen remodeling. We've got elaboration of all the complexity in the dermis, the subcutaneous tissue.
Yeah.
That's going to require that same intensive nutrition that we were recommending to the patient, the appropriate protein intake, vitamin C. Um, we include D. We should do a podcast on why D. Um,
Yeah. The D
and
and K2
zinc.
combo, the classic.
Yeah, right. Of course, the A, was just brief at the beginning of the healing process, but C, D, and zinc, and protein are essential for that, post
Absolutely.
epithelialization remodeling process to proceed, optimally.
Especially, I mean, too, if we're talking about specifically like a C-section patient, as a provider, you have to think even larger scope. What big thing just happened? Oh, you probably need even more hydration, more protein, more support because you also are probably breastfeeding at the same time while trying to heal a wound. So that patient probably needs extra support in a lot of different categories.
Yeah,
Definitely a lot of variables there with every patient to think out there.
there really are. Yeah, that's
Yeah.
right. And that's why they call us specialists, because we embrace that complexity and that um, customization, for each patient, understanding that
Yeah.
patient and helping them adapt.
So what are some key things that you would tell any patient, regardless of what their wound is, to keep an eye out for? Because sometimes we don't see them necessarily every week after it's epithelialized. So let's say we set them to come back in 2 weeks. Or if it looks real good, see you back in a month just to make sure your, diabetic shoe looks good. What are some things your patients need to look for that could be signs that they are getting into trouble with their wound again?
Well, just a close inspection, a daily inspection, because in that early period, again, just a few cells thick, and so it would be very easy for friction or shear, especially in the presence of moisture, to reopen that wound. So yeah, moisture protection. If it's in an area, and we're in Texas in the summer, and gosh, that really creates some challenges. I mean, not to be underestimated. So, do they have a moisture plan? And I've had people, I've told them, especially if they work outside, or they're frequently outside, to carry something with them and attend to that area, dry it. You might need to take some kind of, cloth towels or paper towels or something, and take care of that moisture. You don't necessarily have to use like inter-dry sheets or anything like that. Also, barrier. Use of a barrier might be helpful for that person, especially in a very
Yep.
moisture-prone area or season. Um, Anything that might be affected by sweating or incontinence. So moisture protection, shear protection. If it's in an area, you said that, the C-section patient, one of the things that often leads to early complications before we see the patient or after we call them healed is just the way garments fit. So
Yep.
it's helpful if we tell them, hey, wear the granny pants that come way up, so the elastic band is not over your C-section, uh, you know, uh, incision line, things like that. So yeah, those are things I would call out. And also, don't celebrate your epithelialization with a 6-hour hot tub immersion.
Yeah. And the normal things too, of course, like seeing exposed wound bed again, redness, swelling, pain
Hmm.
at the
Hmm.
site that's unusual,
Yes, right. That's right. Redness,
swelling,
rubor,
induration, all those things,
drainage, all
fever.
those things.
Yeah, if you start getting
Yeah.
random drainage on your sock, even if you can't see a wound, it's probably one of those pinhole situations.
Right.
Yeah, I mean, there's all sorts of things that we teach our patients on discharge just to be mindful of,
Yep.
so they aren't back in 2 days, which we've seen it, we've
We
experienced it
have
all.
seen
We've
it.
had patients they're healed and they come back the next day.
Yeah, they were
I wore
absolutely right.
flip-flops and I went to the beach and I walked around I mean, we had a patient I remember that did that. They went on family vacation the day after we healed him, walked around
Yeah,
in flip-flops on the beach and came back with a wound worse than what we started with. So
we've all
got to
seen
stay on
it.
top of it. So I
Yeah,
guess just a good put a bow on it here is you can heal the wound, but that doesn't mean that that's the end of wound care or prevention, really,
yeah,
for the patients and for our practice.
yep. Excellent, excellent.
Well, thanks for meeting with me again. This is always so fun. I thought this was a really interesting one to talk about, healed versus I'm gonna see you for
Oh,
a couple more years.
and should we throw in, one of my big pet peeves is we cannot even say that a wound is epithelialized if we are staring at anything but pristine, healthy, new skin. And I've lost track of the number of times that I am seeing a patient and they say, well, they told me I was healed. Or I look at a photo, because I'm just looking at quality, clinical
Yeah,
quality, and I look and it says healed on the medical record, and I'm looking and I'm like, this is fractured callus, this is eschar,
yeah,
this is fibrin. That's not healed skin. So, that's maybe a subject for a whole other
a whole other
podcast.
thing. Yeah.
But how do we even adjudicate that you've got an epithelialized wound? It better just be beautiful baby new skin and no bioburden.
Yeah, I always tell folks, we say it's shiny and new because it's literally shiny.
Yeah,
Like you
yeah,
look at
it
it
is.
and it's like a little pink, it's shiny. If it's not shiny and new, it's not epithelialized.
Mhm.
I cannot tell you true how many times I've seen like a hard cap of fibrin, which is vaguely skin colored, get
But it
called
ain't skin.
like healed and nay nay,
Sorry.
nay nay.
Yeah. Or callus. Callus
Yeah,
has low shear strength. It is not an appropriate covering for that tissue. And that's one of the reasons that, all along as we're treating that patient's wound, we need to be removing all those things. And some of it's subtle, that, um, peri wound is very important. We want to remove that callus and we want to be looking at not just a wound that's fully epithelialized, but a nice surround of pristine, healthy, supple skin. No
absolutely.
bioburden.
That's beautiful. That was a good thought to take it home with.
All right.
Well, thanks again, and we'll see you next
See you,
time.
see you next time. All right.
Bye.
Bye.